Welcome to this episode of Brain Trash. My name is Maria. I'm a psychiatric nurse practitioner.
And I'm Tabitha. I'm a psychiatric nurse practitioner.
Today we're going to talk about diagnoses and the impacts of what it is to have a psychiatric diagnosis in 2025. So we know that the autism registry has been a hot topic over the past few weeks to months at this point. What is a diagnosis? Like, how do they track that, right? Like, let's talk about all of the gritty details so you can really have a good understanding and what the implications could be of getting a diagnosis or having a diagnosis, whether that's autism or something else. So Tabitha, talk to me about like what happens when we go in for an evaluation.
Well, when you go into any healthcare setting for like a healthcare encounter, essentially, your visit is coded based on ICD-10 codes. Currently, it's ICD-10. Anyways, it's the International Classification of Diseases, ICD, right? So we have to be able to put a billable ICD code into your encounter to get reimbursed by an insurance company. So this is kind of incentivizing providers, I guess, to come to a conclusion about your diagnosis, which if you think about it in like a regular medical setting, cool, right? I need to know I have hypertension. That way my insurance company will cover the medications that I need, or maybe a device to check my own blood pressure, stuff like that. When it comes to mental health, and I talk about it like this a lot, like if you have hypertension, the doctor says, okay, you take this med, it will lower your systolic and diastolic by this much, blah, blah, blah. And that's what's going to happen. When it comes to mental health, is like, well, here's what your diagnosis could be, but also there's a lot of overlap between this and this. And also it matters like what your socioeconomic status is, how much water you drank, how much sunlight you got. Do you have friends? Do you have a roof over your head? Are you scared about your job security, right? Like these are all things that contribute to mental health symptoms. And when we look at the DSM overall, it's telling us like, well, if you have these symptoms, you have this diagnosis. So there's a lot of diagnoses within the DSM that I can look at and say, I could probably make a large majority of humans fit into this diagnosis if I really needed to, right? And that's fucked up. Like, that is the structure of how healthcare providers get reimbursed. And it also makes us, even on the first visit with somebody, say, okay, I'm diagnosing you with this so that I can get reimbursed, right? Like, I don't like that at all. There are some, like, I guess, I want to call them sham diagnoses, but like just kind of filler things that you can put in there, right? Like unspecified depression or anxiety,
Disorder,
harassment disorders, unspecified mood disorder, right? There are ways that you can get around this, which I think is important to do for a lot of reasons, but it still like gives me the ick that we like have to have that in there in order to get paid for our time.
And also, like, we're not allowed to not put one. So, like, if somebody comes in, like, I remember having, like, a lot of patients and be like, I just want to make sure we're good. Like, and I would do the evaluations. Like, you don't have any disorders. You don't have an anxiety disorder, depression. You don't have anything. You're just, like, solid. So, like, what do you bill it as? So, like, I can't put nothing. It's literally not allowed for me to say that I did this visit and you were good and you have nothing. I have to put, like, adjustment disorder to send it to your insurance company. Like, no, I'm not allowed to put nothing. It's weird. But like if you have a therapist and they're doing cash pay, sure. Like they don't have to put a diagnosis for you. But if they are doing insurance, you certainly have to have a diagnosis. And it has to be, for us, at least in psychiatry, like a DSM diagnosis. It can't just be like encounter with trauma, or like, you know, they have like these other kind of like weird offset kind of things you can put in, but we're not allowed to put those. Insurance doesn't cover that for us.
Funny side note too, there is an ICD-10 code for being sucked into a jet engine as a subsequent event. So the second time it's happened, just by the way, in case anybody cares. I think that's fucking hilarious.
But we're not allowed. We're not also not allowed to get paid for that one.
Nope, we can't.
And the freak event that did happen, we're not allowed, you know. Yeah, I'd like the registry on those people, actually.
Right. I know, right? Has that happened more than once in the world ever? Somebody did it twice, really?
To anybody?
And they lived the first time to tell the story the second time and then do it again. You know, it just doesn't.
Holy F.
Anyways, the reason this is fucked up too, though, is again, there is so much variability. There's so many puzzle pieces when it comes to mental health. And it also matters how your provider is approaching diagnoses, right? Like, are they doing this based on screeners that they've given you at home that you were like in a shit mood one day, or it was the luteal phase of your cycle, or like you were scared for your life because you're being beaten at home, right? Like when you fill these things out, it matters what's happening in your life to influence the way that you answer the screener. And so if somebody's using that for a diagnostic purpose instead of taking extra time to have an actual diagnostic interview with you where we stay curious and keep asking questions and kind of dig into some of that shit of like, well, why do you do that? You know, you end up with a lot of people who have specific diagnoses in their chart that then like label them for life that kind of like hurts them down the road.
Yeah, and they carry that with them, and we've talked about that. And also, like with the screeners, just to like add on, people who are autistic are always like reading these screeners, being like, "Well, I don't have enough information. What does it mean? Do I have a headache?" Like, yeah, of course I get headaches. Should I put yes or should I put no? Do I put always? Like, so like sometimes I can look at how the screeners are answered, and I'm like, man, this person just didn't understand any of the questions, and they just did their best. So, but like, not everyone's gonna read that, and people are just gonna look at like, oh, this is 22 out of 27. They're highly depressed instead of actually like looking at how these questions were answered and ensuring that like the patient didn't take it literally. They, you know what I mean? Like they're assuming like it was answered in the correct way instead of not.
Yeah. I get that so much with neurodivergent clients where like they will say yes to the sleep question that's like, have you ever needed much less sleep than usual or whatever? And yes is always the answer. But then when I did like, you needed less sleep, like you still felt great without it. And they're like, well, no, I was fucking tired as shit, but like I got through it, you know? It's like, okay, but that's not, that's a little bit
Or it was
different.
finals week or something like that, you know?
Or it's like that all the time and it's not a change from baseline, right? Like I just always have had fucked up sleep.
Yeah. And we'll have a whole episode on like neurodivergence and sleep to go over. That will be something you guys will have to tune into. But definitely. And then like when people have these diagnoses, whether it's borderline or like a personality disorder or bipolar, or when parents get a diagnosis for their kid of something like oppositional defiant disorder, then like those are held onto and used sometimes against them or against themselves, right?
Yeah. Oh, absolutely. I can't tell you how many people I've had that come to me and they say, oh, I'm diagnosed with bipolar. And I'll say, okay, cool. Tell me about your manic episodes or your hypomanic or whatever based on what they tell me about their diagnosis. And they'll be like, I don't know what you're talking about, right? Like nobody's ever taken the time to sit down with them and be like, here is the mood spectrum. Here is where you're at. Here is your fluctuation. Does that feel like it fits to you? They just leave an encounter with a healthcare person that says you have bipolar. And in the stigmatized view of what we think of that, what I find a lot of these humans end up doing is they just think if I have a feeling, it's because I'm bipolar. So, like, if I go and buy this shirt that I've been wanting for like a year because I'm really like stoked about my day and I think I look good for once, and I buy this shirt, well within my means, everything's fine, but I bought a shirt and I don't usually do that for myself. Now all of a sudden I'm having a manic episode, right? And so like, oh no, I'm doing something good for myself. I'm feeling good about me. I must be manic. Or, you know, much the opposite on the other end of the spectrum. Like if I, you know, have a day where I just want to chill and hang out in bed, all of a sudden I'm in a depressive episode because I have bipolar. Like I'm not allowed to have a feeling without it being defined by that thing. Everybody has fluctuation in their mood. Everybody has days where, you know, they may verge on some hypomanic traits or they may verge on some depressive episode traits, but like truly, truly explaining to people, hey, this is what this means. And also, does that still feel like it fits for you or for the people that you bring with you to your appointment or whatever? And then checking back in on those screeners to really clarify those questions to find out these things. I don't think a lot of people are doing this. And I don't think it's because necessarily because it's a lot of like bad providers or anything. I just think a lot of places they don't have the time.
Yeah.
They're not given the time and the freedom to be able to do that.
Yeah, like not everywhere has 90-minute evaluations, and we're very lucky because I've structured this business lucky, I don't know. I've structured this business in a way that like we get 90-minute evaluations, and if you feel at the end of 90 minutes you don't understand, then make another 60 minutes. Like I don't care, see them the next week. But like when I was in community mental health, it was like I get 45 minutes with somebody to figure out like a complex issue, and then I get like 15-minute follow-ups if they show up on time, which is kind of gross. And like usually like they'd be on like 30 different medications, right? And there's like 30 different diagnoses and like they've seen 10 different providers and everyone had a different opinion. So the whole thing was just messy. And that's just how the system is. It's just like fucking messy.
Yeah, I think it does people a disservice a lot of times that we have to use these codes. Um, Especially like at the end of the day, there's plenty of research to back up that a diagnosis of any type of neurodivergence can be super affirming, super helpful. But when it comes to other diagnoses, can it explain and give you language for the things that are happening? Yes. But I often find taking on any other diagnoses like as an identity tends to have a lot more negative outcomes than positive. And so looking at these things as just like, oh, hey, I'm a human and I'm experiencing these things, and this is what's causing me the distress. And then we treat that, whatever it is that's causing the distress, instead of treating that diagnosis, I think ultimately has to be the way that we approach this in the future, because the diagnostic piece about it, even within the provider community, like I will see stuff and I'll just be like, oh my gosh, I do not agree with these people at all. And then, all these people are commenting like, yeah, totally. And then the other half, like, no, fuck that. That's not how it is. And these are highly skilled, highly educated humans, right? Who, again, you can send the same person to them and they will come out with different diagnoses.
Yeah, and I mean, like, it varies too on like your approach. Like, what questions are you asking? How are you asking them? Like, sometimes when I have students and I'm like watching how they're assessing patients, like, I'll listen to how the patient answers and like the student's going on to the next question. And I'm taking note that the patient did not fully understand the question or like there's more behind it, right? And like if we don't have the time to like dig into that or like the perception to look at they didn't understand, let me ask that in 5 different ways until like I fully know that they understood the question like at its capacity. I mean, like you're gonna get the wrong shit and you're gonna end up with like labels that are gonna like sit with people. Like there are communities on TikTok where people like have diagnoses of borderline. Some of these people are probably autistic and find out later, or bipolar, or whatever. And it's like, as you said, inaccurate. And then like they kind of take it as an identity. I think trauma too is like another one that's really big, like post traumatic stress disorder, which is fairly common. But like also people are like, oh, that's my PTSD. That's my PTSD. I can't do X or Y or Z because I have PTSD.
Yeah. Well, and again, I do think it's sometimes taking something on as an identity can give empowerment, right? Good language, all of that stuff. But then, like, when we really look at some of these diagnostic criteria, like if I look at the diagnostic criteria for BPD, right? Borderline personality disorder, fear of abandonment. Who the fuck doesn't have fear of abandonment, right? Like,
when you get people who are convinced coming in, they're like, I must have this. It explains everything. And it's like, but have you been abandoned? Like by your parents,
right.
by a partner, by like anyone.
Yeah. Unstable relationships. This is also literally everybody I've ever met has some type of unstable relationships. Unstable self-image. I don't know.
Right?
Never met a woman in America who's never been like, holy shit, my body sucks and everything about it sucks, right? Like, who am I? How do I fit in? How come my body isn't like this or that? And like it just keeps going on, and it's a lot of these, and this is a really good example with this diagnosis specifically, just because it's really, again, it would be really easy for me to say every single person that comes to see me has BPD.
Mm-hmm.
That's not the case. I don't know that I've ever actually put that in somebody's chart, but there are a few, like
one
I'm sure where they came to me with it, or it's definitely there and we've talked about it and all that. So there's I don't even know what the solution to this is, because obviously we still have to have some type of, I mean, I guess we don't, right? We don't have to have it.
If we're in a capitalistic society, yes, we have to have it, right? Like unless we're cash pay, then we don't. But in capitalism, I guess, yeah, right? If people want to use insurance and want coverage, then we're kind of doomed to what they tell us we need.
Yeah. Well, and that's the thing, right? If we look at it and like, okay, all the things that we've talked about right now, so we take all that shit away and we create our own new system, what does that look like, right? If we don't have a DSM, and it's just something entirely different or nothing in its place, and we don't have to have a ICD-10 code to get reimbursed, you can pretty much have anybody anywhere saying whatever the fuck they want and giving whatever medications they want for God knows what reasons. And that could get real dicey too, right? So I don't know that there is like a, hey, this is the answer type thing, but I think that acknowledging how fucked up it is and acknowledging the flaws that it carries is really important as a provider when you are looking at a patient saying, okay, I know I have to diagnose you with something, and that doesn't have to be something super concrete on our first visit or our first 5 or 10 visits, right? Unless it's something that's very glaring, like specifically with bipolar, I will very rarely put that in someone's chart on our first visit, right? A lot of times it's that unspecified mood disorder, unless it's been very clear episodes of mania or hypomania and all of that. But even then, right? A lot of times when I ask people and they do know about their mania, I'll say, okay, well, tell me about that time when that happened, if there's been one manic episode. And they're like, oh, well, it was the time where like I had been smoking weed for 20 years and then I stopped. And for that week, I was manic. And I'm like, okay, but that's also like the effects of a substance. So that doesn't count. So I still will be like, okay, great. And I'll talk to them as, I'm not going to like burst somebody's bubble and be like, I don't think that's bipolar. But also say like, hey, let's stay curious about that. I want to hear more about it next time we meet. And maybe we could talk a little more about what the other, factors were in your life at that time and see what's up.
I think that's like the thing for providers is like stay curious, right? Look at life circumstances and then also like have the conversations with your patients. And if you're a patient, you can have that conversation and say like, so what are my diagnoses? And sometimes like I find that it's kind of awkward as a provider to like list it off. Like I always do whenever I've done an evaluation. I'm like, okay, this is what I'm giving you and this is what I'm putting in your chart. And I always offer the option to get vetoed. And like but as a patient you can say like I don't want that in my chart, like that's fine, can you please not put that in the diagnostic section, or like can you not put that as an F code, that's your keyword, don't use an F code, or like can we like re-talk about that one. But then sometimes providers will take that as like I think this person's drug seeking because they didn't get the diagnosis they wanted from TikTok, so then we get like the gaslighty stuff that comes in.
Yeah. That's the hardest part of this. It's not, hey, here's the guidelines for treating hypertension and here's the guidelines for what is hypertension. It has to be over this number, very specific metrics. It's like, hey, here's these symptoms, but also this, and also maybe not this. But if this happens, then it's not that, and it might be this instead. And also the symptoms of 5 or 10 or 20 different diseases overlap or disorders overlap. And you could get any one of those things on a different day,
Or depending like what you look like, right? Like we know health disparities are a massive thing. And like if you walk in with the same symptoms being black or white, you're going to come out very probably, if you have a white provider, with, different diagnoses, even if it's literally verbatim the same exact evaluation. So there's a lot of like different factors that just go into like, I think providers educating themselves and like being aware and like opening their mind to a lot of the ethical concerns around this, especially for like kind of understanding like how does the person feel and identify with that diagnosis. And that's always something I always wanted to ask too at the evaluation, like tell me how you're feeling about this, tell me like what's your vibe on this. And sometimes people would say like I don't fucking agree, or like this makes more sense, like everything in my life is kind of coming together. And if you have like neurodivergence and you're being diagnosed with autistic, like that could be something that is like extremely validating. But in the same end, like having a diagnosis of bipolar that you're carrying with you that is or is not correct could be pretty devastating.
Yeah. I think that I'm always like, I think the vibe I got throughout all of my schooling, all of the like internships and hours I did with other people, not all of them, but most of them, was kind of like, I need to figure out what's going on with you so that I can treat it or fix it. And really what I found in actual practice to be most effective is like, let's figure out together what's causing this for you, and then figure out, which direction we're headed. And if we ever need to pivot, that's totally fine too, because I think, again, that piece of like very rigidly saying this is what you have is such a dishonest way to approach this. We don't know. There's too many things about the brain that we don't know. And there's too many factors to mental health to say, hey, this is how it is and it will always be this way for you. That's just not the case.
I think that's where you get a lot of the dichotomy of like, people who say, I'm a provider and I know best and like I have studied this, and like humble yourself, bro, because like shit, we don't know everything. If the researchers don't know everything, neither do we.
I specifically like listened to some stuff recently, from a well-known psychiatry podcast, right? And like well-known researchers saying like, oh, well, ADHD doesn't ever get worse in adulthood. It gets better. And retrospective and prospective studies both show this, blah, blah, blah. Yes, those studies do show that. And those studies don't include anybody else who has that, because it's women, it's people who are not white, it's people who have not been historically diagnosed in childhood to where you could even do a perspective of it,
Yeah.
like
Moms postpartum, when we know like the dopamine is depleted after the estrogen gets all fucked up after you give birth, like, yes, mom brain is a thing. And like for ADHD, it's like worse. Your ADHD will get worse after you have a baby. And sometimes it's just like your Adderall is just not going to do the same thing postpartum. It's just not.
And so we have these people who are, highly respected people in the community, whatever, cool. But I'm listening to this as somebody who is like, yeah, I hear what you're saying. And we also have to keep open that space that like, maybe that research doesn't include people like us, people who are late diagnosed, high masking individuals, people who have had to mask because of their safety within their community, their culture, their family, whatever that looks like. They're not allowed to let those things out, right? We may not be up and moving around and going blah in class because I know if I get in trouble and I go home, right? Not me personally, but like
Your
if
parents.
I get in trouble and go home, I'm getting beat, right? Or I won't ever be able to do this thing or play my favorite sport again, right? That will motivate a person to not behave that way. And if that's just compounded by different factors throughout your life, of fucking course you're not going to let that shit out as much as you want to, as much as it's stuck inside you. It's just like, oh, I can't do that.
Yeah, and there are like ways that people internalize things, and then like later in life they end up having problems and being people pleasers and just like not having like the ability to speak out for themselves because they've been, holding everything in their whole lives, like, not able to express themselves in the classroom, like just hold everything in. So I
But
don't know.
then we have all of this research that just gaslights the shit out of them once they finally find something that makes sense to them.
Yeah, yeah, and the research and the providers who are then like, no, that can't be possible, right? And look for every reason to say like, no, you shouldn't be on TikTok self-diagnosing. No, you should not be like looking up these things. You do not fit. You're not forgetting things all the time. You're not this, you're not that. That doesn't count. Like that, dude, that's so often. All right. Thanks for tuning in for this episode. We appreciate the listen. Please hit subscribe, hit follow, leave a comment if you agree, disagree, ideas on like how the system could be overhauled. We're here for it. So thanks for tuning in, y'all.